Hello, Dr. Maruzir again, and in this video we will continue our discussion about symptoms of heart disease. If you have any question, you can email me here at ammar@goodrational.com or comment your question down below. Here we will discuss the 7 main groups of symptoms of heart disease, and at the end we will point out 5 more focused symptoms that could point to a heart lesion. The 7 main groups of symptoms were symptoms of pulmonary venous congestion, low cardiac output, central chest pain, syncope, fatigue, palpitation, and systemic venous congestion. Let's talk about each one individually. First, we have symptoms of pulmonary venous congestion. These occur with left-sided lesions like left ventricular failure or mitral valve disease. Now, if the left ventricle is failing or if the left atrium is not able to fill the left ventricle with blood during its relaxation, blood will accumulate back in the pulmonary vein, causing its congestion, and with backward pressure to the lungs, causing edema of the pulmonary interstitium and alveoli. Now, what a patient with pulmonary edema will present with? He will have 4 main complaints. First, he will have difficulty breathing, what we call as dyspnea, because it's water standing in the face of the exchanging property of gases of the alveoli. Next, he will cough and might have sputum, pinkish colored sputum. Why? Because at the end of the day, it is blood that is in the congested pulmonary vein and the engorged pulmonary circulation. So, cough, hemoptysis, and difficulty breathing. 2 more symptoms left: orthopnea and paroxysmal nocturnal dyspnea. Orthopnea means difficulty breathing when lying flat. So why does it occur? You and I are healthy individuals, standing still or walking. The gravity pulls the blood from systemic veins down to the lower limbs. When we lie flat, blood gets redistributed from the legs back to the heart, increasing its preload. But as healthy individuals, our heart can accommodate this increase in preload as if nothing has ever happened. Now, when a patient will have pulmonary edema and left ventricular failure or mitral valve disease lies flat, as you can see here in this picture, blood gets redistributed from the legs back to the heart, increasing its preload. Now, logically, patients who have pulmonary edema during the day will have more edema during the night when he lies flat. More edema when more blood is coming to the lungs, and more aggravation of symptoms. Symptoms will be aggravated moderately or severely, depending on the severity of the heart lesion. If the heart lesion is moderate, the patient will have orthopnea, described as difficulty breathing when lying flat. But if the lesion is severe, the patient will have paroxysmal nocturnal dyspnea, or PND, which simply means the patient is walking from sleep, fighting for breath. Next, we have symptoms of low cardiac output. These symptoms also occur in left-sided lesions like left ventricular failure or stenotic valvular lesions of the heart, mainly aortic stenosis or mitral stenosis. Now, left ventricle is failing or not able to pump sufficient blood to the circulation. What will happen? Let's start with the coronary circulation. Decreased perfusion to coronary circulation will cause anginal pain. Next, decreased perfusion to the head and neck areas will cause mainly cerebral flow, will cause syncope, blurred vision, and dizziness. Next, blood will continue supply all tissues, mainly muscles. Decreased perfusion to muscles will cause claudication, which means pain of arms or legs when using them. And decreased perfusion of all tissues will cause fatigue. So, symptoms of low cardiac output are 6. anginal pain, dizziness, syncope, and blurred vision, claudication, and fatigue. Next, we have symptoms of central chest pain. Central chest pain is the most common symptom of heart disease, and it can happen by 5 different types of diseases, and you have to differentiate between each one of them. Beginning with stable angina, acute coronary syndrome, aortic dissection, pericarditis, and cardiac necrosis. The first two, stable angina and acute coronary syndrome, are caused by atherosclerotic plaques, occluding the coronary circulation. Now, let's describe stable angina. Stable angina is a retrosternal pain. Why retrosternal? Because that's where the heart's placed, behind the sternum. That is heavy or gripping pain. Why heavy? Because the heart is a muscle. And in this case, in the case of stable angina, it is caused by atherosclerotic plaques. There is occlusion in the coronary circulation, so the demands of the heart exceeds the supply of oxygen and nutrients. And when a muscle is doing an extraneous exercise, having more demand than supply, the pain will be heavy in nature. Think of times where you were in gym exercising. At first, you were lifting dumbbells perfectly, but at the end, when you finish and just before wanting to leave, you get a couple of dumbbells to lift, strip down naked, and get in front of a mirror to see your fabulous six packs, which I have combined into one pack, single pack, to abandon this behavior. Anyhow, you start lifting dumbbells, but you feel as if they were heavier than they were when you start exercising. So retrosternal, heavy or gripping pain. What else can we say? Radiating to the arm, left arm, shoulder, or neck. Why? It's embryological dermatomes, always playing tricks on our bodies. It is also provoked with exercise and relieved with rest. Why? Because it's a partial occlusion, not a complete occlusion of the coronary circulation. It's a partial occlusion, and with blood coming through the occlused artery is just enough to meet the demands of the heart. But when demands increase, just as with exercise, pain knocks the doors. Next, we have acute coronary syndrome, which is similar in features as stable angina, but it's more prolonged and happens at rest. Why? Because there is more occlusion of the coronary circulation. Next, we have aortic dissection. Aortic dissection. It is severe tearing pain. What words can we use for a wounded vessel other than tearing? So it's severe tearing pain, radiating to the back. Why? That's the course of the aorta. Upwards, backwards, and downwards. Downwards, just in front of the back. So the pain radiates to the back, in between the scapulae. So severe tearing pain radiating to the back, mainly interscapular area. Then we have pericarditis, which is inflammation of the pericardial sac. Inflammation of the pericardial sac. It's a sharp central pain. Why? Because the pain is transmitted through the innervated pleura. How? The pericardial sac, which is inflamed, irritates the pleura, which transmits the pain. So this pain is worse with respiration and movement, because these behavior make the pericardial sac parietal layer touch the pleura. Next, we have cardiac necrosis, which is sharp stabbing pain left mammary area, and it is associated with anxiety. So central chest pain, 5, stable angina, acute coronary syndrome, aortic dissection, pericarditis, and cardiac necrosis. Next, we have syncope. We've mentioned it before in symptoms of low cardiac output, but we're mentioning it again because it can be caused by non-cardiac causes. And the main three reasons for syncope are vascular, pains in the vessels, obstructive, problem in the heart, or arrhythmias. Let's talk about vascular. Vascular, like vasovagal attack, sudden drop in blood pressure can cause syncope, or postural hypotension, or postprandial hypotension. Postprandial hypotension, blood gets redistributed to the gut. Then we have micturition syncope, also vascular. Micturition syncope, syncope during urination. Yet, it is not known cause. You don't have to worry about the cause. Just know it is something there. Micturition syncope. Next, obstructive, problem with the heart. Aortic stenosis. Left atrial myxoma, obstruction in the left atrium. Ball and valve thrombus. Next, we have arrhythmias. Now, the cardiac specific syncope. We have exertional syncope, which means there is a problem in the left ventricular outflow that is not apparent during rest, but during exertion, cerebral demand of the oxygenated blood exceeds the supply, causing syncope. Example, aortic stenosis. Then we have positional syncope. Positional means cerebral blood flow changes with posture, or cardiac outflow changes with posture. Same and the same thing. Examples, left atrial myxoma and ball and valve thrombus. In left atrial myxoma, more obstruction at upright position, and dyspnea may improve while lying flat. This phenomenon is called platapnea and can occur with other disorders as well. We also have syncope at rest. Then fatigue. Fatigue can be caused by a heart lesion or as an adverse effect given for a heart patient. Heart lesion. What are these? First, we have left ventricular failure or heart failure in general. Decreased perfusion to tissues will cause fatigue. Other disease. We have as a systemic manifestation of an infection. Always remember, one of the systemic manifestation of infections is fatigue. So, systemic manifestation of an infection, we're talking here about pericarditis, endocarditis, and heart failure. Also, as an adverse effect of drugs, think beta blockers and diuretics. Beta blockers cause poor sleep, causing fatigue. Diuretics causing electrolyte imbalance, causing fatigue. So beta blockers and diuretics. Next, we have palpitations. These represent an increased awareness of the normal heartbeat, or a sensation of a slow, rapid, or irregular heart rhythms. The most common arrhythmias felt as palpitations are premature ectopic beats and paroxysmal tachycardias. Premature beats are felt as a pause followed by a forceful beat. However, paroxysmal tachycardias can be described as a sudden onset of rapid heartbeat not related to exertion. Atrial fibrillation is described as irregular palpitation at rest. Bradycardias, however, it is almost always nonsensed, but can be felt as slow, regular, heavy or forceful beats. And forceful heartbeats are indicative of volume load. Now finally, symptoms of systemic venous congestion causing peripheral edema. Peripheral edema. Why does it happen in the case of left ventricular failure? Left ventricular failure causing decreased perfusion of all tissues, including kidneys, causing activation of renin, angiotensin, and aldosterone system, salt and water retention, and pitting edema in dependent areas. However, in case of right ventricular failure or tricuspid regurg causing systemic venous congestion, portal hypertension, ascites, jaundice, and backward pressure, dyspepsia, and edema in the lower limbs. Now finally, focus symptoms that could point to a heart lesion. We have embolic manifestation, jaundice, cyanosis, fever, and history. Embolic manifestation can indicate mitral valve disease, or artificial valves. Jaundice can indicate systemic venous congestion or artificial valve. Cyanosis can indicate congenital cyanotic heart disease, fever, and history like personal history, family history, and drug history. Thanks for watching. See you in the next video.